Hello, everyone, and welcome back to Couchside Cancer Chats. This is the podcast where we bring oncology conversations from the exam room to the couch, helping vets, nurses, and our pet owners out there understand pet cancer care better. I'm Dr. Anna Markey, a veterinary oncologist, and today's episode is one I've really been looking forward to. It's diving into something that sits at the right center of cancer care. We're talking about pain management, but not just medications. We're talking about how we understand pain, how we recognize it, and how we explain it to families. So to help guide us through this conversation today, I'm joined today by Dr. Anna Markey, who focuses on pain management, palliative care, and also hospice care for our patients. Anna's passion for working with geriatric and palliative patients developed early in her career as a small animal vet. After working in general practice and caring for her own two geriatric dogs, both of whom lived to an incredible age of 17, which is amazing, she began to realize there was much more we could be doing to support our aging pets and patients and our chronically ill ones. Her background in internal medicine and emergency care gives her a strong foundation for managing these complex cases. She has also completed a postgraduate certificate in emergency and critical care with first-class honours. So that's really, really great to have her on board for this today. And more recently, she became an IAAP-HPC certified hospice and palliative care vet. Anna, thank you so much for joining me today. It's really great to have you on this podcast and give your insights to this conversation. Anna, when we talk about pain in our veterinary oncology patients, one of the things I think is often missing from everyday conversations is how complex pain actually is. Many people, and honestly sometimes us vets as well, think of pain as one single thing. But I think pain has many different biological mechanisms and categories, and understanding those categories can completely change how we treat our patients. So I'd love to start by talking about these different types of pain we see in our veterinary patients. So I suppose, Anna, when we talk about pain in medicine, we often hear these terms: adaptive pain, maladaptive pain. Would you be able to make some sense of that for us on these terms?
Oh, thanks for the nice introduction to begin with. And I guess before you jump into it as well, I just want to say that this whole topic is pretty close to home for me, because one of those 17-year-old dogs ended up having a nerve sheath tumor. So it really puts into perspective, I guess, these different sorts of pain, because he was arthritic as well, and he had other inflammatory diseases, and then that nerve sheath of everything else. And it really, I guess, changes the way you do think about pain. And that's when I sort of dove deeper into it and started understanding this a little bit more. But I guess one way we can think of, yes, pain is adaptive versus maladaptive, but we could also think about it as nociceptive versus neuropathic versus nocioplastic as well. And they don't have the same distinction, but it's different ways of looking at pain. And one is asking is what job is the pain doing, and the other asking is what mechanism is sort of generating it. So we need to look with both lenses, okay, when it comes to managing it. So before I even jump into adaptive versus maladaptive, I just thought I'd touch base on that nociception is not the same thing as pain. And I think it's something as clinicians that we forget sometimes, because we just think about nociception. I mean, it's one of the things that we're really trained on. So just a reminder for everyone listening, nociception is a nervous system detecting and sort of encoding a potential harmful stimulus. So that's detecting pressure or inflammation, tissue injury, heat, chemical irritation, stretch, or all of it, or bits and pieces of that. Whereas pain is more, or is that conscious experience that emerges from that processing. So even as vets, we use the IASP, so the International Association of Study pain for the study of pain definition. And that's why that matters so much more. So that pain is basically an unpleasant sensory and emotional experience. And they're very explicit that pain and nociception are very different phenomena. Okay, so when I explain this to vets, like nociception is the physiology, pain is what we're seeing, the experience.
Yeah, that's a very important distinction, I think, for us vets to be reminded of as well.
Yeah, and like the difficult thing is like in pets, like in humans, you get a verbal report, so you're actually seeing it. In animals, pain is obviously it's what we're seeing, and it's what, I mean, it's not even what we're seeing sometimes in the clinic. It's what the owners are reporting to us. But I guess, to get back into it, like, so when we think about adaptive pain, that pain is essentially serving a purpose. It's serving a protective biological function. So it's essentially the body saying something here is threatened. We need to protect it, rest it, guard it, don't load it, like a cruciate injury or a fracture. Basically, don't make it worse. And in that setting, pain is usually unpleasant, but it's also useful. So like examples could be like just your standard post-op pain, a fracture, inflammation. This is how I usually explain it to owners if they want more detail on it. But it's situations where the pain system it's essentially doing what it's evolved to do. It's tightly linking tissue thread, and with essentially like, and if you remove it or reduce that driver or that stimulus, essentially that pain will go and it'll settle. So the pain's there. The pain serves a purpose, and it's proportional. So once that fracture is on its way to healing, once we suture that wound, once we manage that inflammation, the pain subsides. Okay, so it serves a purpose. Exactly. Whereas maladaptive is essentially when that relationship breaks down. That pain stops acting like that clean alarm system and starts acting a bit more overprotective or like an over-responsive amplifier. So the biological changes underneath that are really, really important. So at the periphery, so your ongoing inflammation or injury can make nociceptors more excitable. Their threshold then will drop, and then you get more easily firing, and sometimes the firing can become spontaneous. So that's what I'm talking about there, is that peripheral sensitization. So that falls within your maladaptive pain. And then we've obviously got your central sensitization. So that's your repeated nociceptive input that sort of increases the responsiveness of your neurons in the spinal cord and in your central nervous system. And with all of this, that's when repeated input essentially gets amplified. Minor input can actually start feeling disproportionately painful, and non-painful stimulus can become painful as well. That's important to educate your owners on as well. And then the pain can spread essentially beyond that original site. So beyond where the original damage or tissue injury has occurred. So it said, like this system's no longer reporting tissue damage. It's changing the way it's processing that danger now. So that's sort of like the two big in adaptive and maladaptive pain. I hope that makes sense. It's a very complex.
I think so. I think that's a really helpful explanation. Is it? I think sort of from what I'm hearing, especially around the peripheral and central sensitization, that's probably the reason we as vets want to be in there with our early pain relief, right? So that we don't let this sensitization happen. Is that a fair conclusion? Or
yeah, I 100% agree. And it's I think understanding the disease processes, so whether it's cancer or any other chronic disease, is really helpful in that, and understanding that you can get these maladaptive pain conditions really, and if we're getting on top of the pain early, we're less likely to get these maladaptive sometimes conditions. And truly listening to the owner and what they're coming to us and telling us is their experience at home is really important.
Really agreed. Yeah, I think that's why sometimes probably in addition to what the owner is saying is quite nice, probably as part of your service as well, to see the dog or a cat in their home environment, because you can probably make some really important observations there.
Yeah, it's it's extremely helpful. And I don't think, like, coming from internal medicine and seeing a lot of oncology patients, I don't think I truly appreciate the difference between like these adaptive and maladaptive, or all these maladaptive pain conditions. And like, as an example, I just went and saw a patient just then, and I don't know, he's got some sort of neck disease. I don't know if it's cancer or if it's, disc disease or even just musculoskeletal, but it's hugely different what I'm seeing in the home. Like, even just the shift in his gait at home, and after he was over stimulation of the visit, within an hour, right, his gait completely changed, his attitude and demeanor changed. And you just don't see that in the clinic, because they're usually so overstimulated and excited or stressed and hiding. So that's where I guess listening to the owner and what their experience is at home really becomes useful, especially when differentiating adaptive pain.
Yeah, no, absolutely. I think that's been really, really clarifying, Anna. Thank you. I think sort of talking about these different distinctions, we talked about adaptive, maladaptive, and I think probably another distinction we often make is acute versus chronic. How would you sort of look at that in practice, at the differences there?
Yeah, and I guess that distinction's like really practical for vet medicine in particular. Okay, because you've got your acute pain, you've got your chronic pain, and a lot of us have seen acute on chronic pain that often looks very different as well, or it gets missed for different reasons, and each of them need different management strategies. And we've got a lot of pain guidelines out there now, like through AHA and WASAVA and all that. They've got fantastic that it explicitly note that presentation of acute and chronic pain differs. So that's really helpful for the clinician. And assessment and client communication, even management, needs to be approached differently. So with your acute pains, they're the ones that owners tend to recognize, and we tend to recognize quite easily.
Yeah.
They have a very clear trigger. So it might be surgery, trauma, pancreatitis or urinary obstruction, or ulcers, or, anything like that. So very, very obvious things. And in a consult room or in the hospital, these patients are obviously painful. These are the ones that no one tends to miss. And they're painful, maybe palpation or even visually, like you can see them standing, or a cat with a severe grimace or movement, appetite and changes. And I guess that's why it's acute pain tends to be a little bit more straightforward, and why repeated clinical assessment with like standardized acute pain scales sort of emphasized in the guidelines. Whereas, so that, I guess, like that acute pain looks like something's wrong now. Like it is really, really
more urgent or emergent. Yeah,
exactly. So whereas your chronic pain is obviously quite different. Chronic pain, if you look at the actual definition through the International Association, they describe that as lasting or reoccurring for more than 3 months. So that's a key difference, but it's also usually less dramatic, and there's more of a behavioral component as well than acute pain. So it's something, chronic pain, I guess, is something that owners tend to miss, and even vets, I see vets miss it all the time. And I don't think that they're necessarily missing it in the clinic. I think it might be the owner's not reporting it, or maybe the animal's not presenting like that in the clinic. And because we're usually watching for more of those acute pain sort of signs, while chronic pain, exactly. And whereas chronic pain often shows as more gradual sort of behavior changes, mobility changes, mood and interaction, and changes in those routines. And I'm usually saying to owners, like, these little things that you're seeing, they're the key things that I'm looking for chronic pain, and I see it all the time in the home. So it's usually the way that they're presenting is usually like the pet isn't quite right, or not quite themselves anymore, rather than something big and scary happening in the like fractured, or whatever, something really obvious. And it's like those subtle changes, like the cat not jumping on the counter, or the dog that's they could have like some bone pain or something like that, and they don't want to jump in the car, or they step in the car rather than jumping. And just, I guess, with owners, just like helping, I guess you can direct your questions a little bit to try and differentiate between the two. And then I guess we can probably jump into like what I guess what acute on chronic, I guess, is, and that's a
totally
label.
Yeah, definitely. I think the chronic ones, I mean, I do see acute ones as well, sort of in my line of work. But I suppose the majority of the patients I see, they're geriatric. And I think the most classic example of chronic pain is arthritis. And a lot of them will just say, oh, I just think my dog's getting older.
Yeah, they're getting old, or they're a little bit lame,
Yeah.
but that's just aging. And I'm like, that's not, age isn't a disease.
Yeah, that's quite right. That's a daily conversation I'm having. Yes. Definitely not a disease. But yeah, it's around these sort of observations that people made and what sort of categories they get thrown into, especially if it's a gradual thing that sort of creeps in. Yeah, it's quite hard.
Yeah, and I guess that, like, clinically, that's where, like, there's some big, like, practical differences with, like, management, because your acute pains, usually your rapid stabilization. Like, if you have one of your osteosarcs come in with a fracture, like, that's very different. Whereas chronic pains, I guess, more about that longer term management. So
absolutely.
Like, yeah.
Yeah, definitely. It's sort of catering for the individual and how they obviously need things. Absolutely. And yes, I think when chronic becomes acute, sort of our acute on chronic situation, that's probably the big prompting factor that we need to obviously do something right now, but probably will prompt a bit of a clinical strategy and a management plan.
Yeah, exactly. It's and I guess a lot of the time, sometimes I guess with some cancer patients, we're probably seeing them at that acute on chronic potentially. That stage, like that, you know, like, let's just use the osteosarc as an easy example, like the fracture, but that dog's obviously going to have had severe bone pain leading up to it, which most owners think it's arthritis. But yeah, being able to, like, know the distinction between adaptive and maladaptive and acute and chronic, I guess, directs the way that we manage and treat those cases, and educate the owner as well. Educating
absolutely.
the owner.
Yeah, absolutely. And sort of give them some tips what to look out for and how to manage that in the home. Absolutely. I suppose talking about these different pains in our cancer patients, and we know that cancer patients, dependent on where the cancer sits, or if it has spread, which organs are involved, can be caused through multiple pain mechanisms. I sort of wanted to get a bit of an understanding of sort of what are the main types of our pain there that we can probably expect.
Yeah. So I guess, like, in the cancer patients that we're both seeing, I would say that most of the pain it's often mixed. It's not one single type of pain. So the way I usually break it down clinically, we usually think about your nociceptive pain, which can be like your somatic, your visceral, and your neuropathic pain. And like I said, sometimes I have a mixture of it. So somatic is more like, it comes from your structures like your bone, your muscle, soft tissue. And it's often more of a localized, and like localizing and feel like aching or sharp and throbbing sort of pain. Whereas visceral is very different. And a lot of this obviously we're getting from human medicine as well, but we it overlaps a lot. Visceral pain is the pain that we're getting usually from your internal organs. And it's more of that, it's more of a subtle pain. So like a dog with somatic, like a bone pain or a muscle pain might be lame on that leg, whereas visceral pain might present very differently, and it's sort of harder to pinpoint. It's usually more of like a deeper cramping or a pressure, or even a stretch pain as well, that can happen with some cancers. You can also get referred pain in these cases of pain. And then your neuropathic is obviously when your nerves are involved, or your nervous system is involved in some ways, whether it be injured, like nerves be injured or compressed by a tumor, or it can be related to treatment as well. And absolutely. In humans, they're usually describing it as like that burning, shooting, tingling, electric sort of feel. And I guess we're also, when thinking about these types of, like, I guess, these different mechanisms, I'm also thinking about like background pain versus breakthrough or incident sort of pain. So like the flares that happen despite otherwise reasonable control of these different mechanisms. So obviously a lot of them are experiencing one or all of these mechanisms at once. And a lot of the time, the treatment works best when we're matching to the type of pain that they're probably going to be experiencing, or most likely, because they can't tell us. And what we're seeing clinically, what we're also seeing clinically, so looking at that whole picture, not just what the scans are saying, the type of cancer that we've got back on, histopath or cytology, not just what the animal looks like in the consult room, but also what that owner is explaining to us. So using all that information, figuring out what type of pain mechanisms are probably involved, and treating that type of pain rather than thinking about all pains as the same. And that's probably why I think it's really important to try and know the differences between them, because they're going to present very differently with different types of cancer.
Totally. Yeah, absolutely. Something, or maybe sort of a bit of a personal question there. I was just thinking around, especially this visceral pain. I often find, or that's at least my impression, when dogs have very large liver masses, for example, I find they are incredibly nauseous sometimes. And I think, I suppose, what do you think about it? I obviously give them pain relief, but at least in this initial phase, until that's controlled or dealt with in whatever form, I think they also need anti-nausea medication, or it's to sort of cater for these other symptoms the pain might be causing, I guess.
Well, exactly. Or like that stretch pain in like a mass in intestines, like the same sort of thing. For sure. Or like we were talking about before we jumped online, like the visceral pains that you can get from like effusions, and I guess like even that will be very different as well. Like it might not be necessarily a drug, it might be tapping them and removing, I guess, that stimulus, and then treating the cancer as well can also improve that. So yeah, it gets extremely complex. We've sort of
it definitely does. But I think sort of the main thing is that sort of identify what is going on right now, what might be the pathways, and sort of adapting to this. Because I think you said something very important there. You might have your initial cancer, and then you're dealing with your whatever pain management, but then you start rolling through treatments, and that might either alleviate some pain and you have to tweak the drugs differently, or it may inflict pain and you have to temporarily cater for that. I'm especially thinking about patients who go through radiation or get vaccinations, injections given into certain muscle groups. That can be incredibly painful. It's temporarily, but
you were just saying then, I was just thinking about like a radiation patient that I had, like yes, the radiation was palliative to manage it because it was a non-surgical tumor in the retroperitoneal space that he had, but then he went through extreme radiation pain. And another important thing I think for clinicians is making sure, like when we know that the patients are potentially going to experience these sorts of pain, is regular follow-ups is like very
absolutely.
Before the owner is presenting with this animal in a crisis. Okay, like I've got this patient radiation of a huge area that was like 20 centimeters by a huge amount. Like we know that it's probably going to get sick from this potentially, and that's not our aim. Like, but it unfortunately does happen. So I was having like daily follow-ups with this patient in the end, get him through that, and then his quality of life dramatically improved, which was like fantastic, because that was the whole point, and he wasn't on a million meds in his end of life.
But that's right.
But without that, he would have been dead, or he would have just been like extremely uncomfortable. Well, he was extremely uncomfortable. Like that visceral pain. Like his retroperitoneal space was full of tumor. So it wasn't.
No, that would not have been nice. I think there's a lot of owner education around that as well. What are the expectations, and sort of for us to be flexible in how we manage them, and that we have to adapt to what is the situation now. Definitely. I think that sort of leads over to a bit of the next sort of conversation point for me, which I think is something that you guys do incredibly well in palliative care, is sort of translating these complex medical concepts into a language or a way that owners can understand this. So I suppose when you walk into a home and you're talking to a family who may already be overwhelmed with the cancer diagnosis, struggling with comfort care, how do you explain these complicated pain concepts to them?
Yeah, that's a good question. And I I guess like when I was in like referral medicine, I don't think I did it very well. And same with GP, I didn't explain it very well because we're not, I mean, we're trying in the medical, but a lot of vets will explain medical to owners in not lay terms, and they have no understanding, and they don't want to be embarrassed, and they don't want to say that they don't. So I think it's important to remember that they don't need like a full pain lecture because they're not going to understand it, or they're going to shut down. And they need it in a way to make sense of like essentially what they're seeing. So sometimes it's about like things out in the home is very, very helpful to help them understand that might be chronic pain. So like in the home, when I'm in a home with like a family, I'm trying to like avoid, look, unless they're medical, that's probably a good point to make as well. I usually will always be upfront with a family and say like, are you medical in any sort of way with chronic diseases before? Because there's some people that medical literacy might be better. Okay. And in that case, explaining it like I explain it to a colleague or one of my nurses. So that definitely changes the conversation. Sometimes they just appreciate layman's terms, but usually I'm avoiding like your heavy terminology like neuropathic or visceral and things like that because they'll shut down, and it's not helpful. They shut down and then they just go back into denial and ignore what you're saying.
Yeah, that's probably not what they need in that moment because they're probably
exactly. Or they've done research and they've seen all that. So I'm trying to translate pain into things that they're seeing and they feel like they're observable to them. So like what's going to us, what has changed? So even this morning in a consult, I was like, get up some videos from a few years ago. Let's look at these videos versus now. And what looks comfortable in their daily life. So I'm explaining pain in, it can look different depending on what it's coming from. So for example, bone pain might look like stiffness or reluctance to move or difficulty getting comfortable, like restlessness, whereas nerve pain might look more like restlessness, trembling, sudden sensitivities that some owners might notice, like they might notice a jolt or an inability to settle. And that way we're sort of grounding the conversation in the pet's behavior rather than that medical jargon that gets them a little bit lost. And I'm also, I guess, while I'm there, I'm also trying to give them permission to let go of the idea of their pet, like pain in their pet is crying and then that obvious acute pain. So that's where I'm trying to get to with them. So I'll often say that animals that are like some animals are very good at masking discomfort. So we're looking for those. So those, like we said before, like mobility, posture, like even head carriage and sleep, breathing and appetite and I guess their interaction with their environment and like, doing their happy things as well. So like some osteoarthritis patients I've seen, they're weight bearing pretty well. But I'm watching them in the home and I'm like, sometimes the owner, when I'm there for a while, I'm like, that breathing, that's not normal breathing for a in their home that's nice and relaxed, that is asleep, like that's really heavy breathing or that's panting still. And owners, I guess, that understand that the science basically becomes a little less overwhelming because we're no longer asking them to understand like these difficult pain mechanisms in a completely abstract way that means absolutely nothing to them if they're not medical. And instead we're focusing on recognizing what pain means in their pet, in their home, in their everyday life.
What does it look like?
What it's potentially going to look like as well. And that's the goal. It's not like we're the medical person and we're not it's not about teaching them like the physiology of what's happening, but it's helping them more comfortably recognize suffering and understanding what could happen, knowing
and sort of navigate that.
And like things that we can look out so we can reduce, I guess, maladaptive pain or chronic pain and things like that, or acute flare-ups. So that's what I'm trying to do when I'm in the home, and that's how I sort of translate that really complex medical terms that we've already been through at the start of this into like everyday helpful information for that client.
Yeah, definitely. I think it's again about educating the owner, sort of pointing out what their pet might already be experiencing, and sort of how you see that in their behavior, or change in breathing pattern or eating or whatever it might be. I find the same sort of in the consult room, to sort of really listen and pick apart what are they doing at home and what does it look like, and then sort of give them these practical tools to gauge things. And whenever I have a palliative care, I suppose, consult and they have XYZ pain medications, rightly or wrongly, I always send them home with the fourth one, say, right, this is your standby medication. And if things are not great, let's be honest, it's going to be an evening or a weekend. And then they have.
You're going to be by yourself and panicking and
by yourself, big
your
dog.
phone's dead.
Yeah, exactly. At least, this is your comfort, your peace of mind. Just give that. And then, until you can get to the vet, I suppose. But yeah, I think it's sort of making them feel okay around the situation, normalize it, I guess, in a way. Well, that was very much for our pet owners right now. I was just going to transition a little bit to our vets that are probably listening here and often having to have these conversations or having to manage these patients in practice. What would you say are some of the maybe key mindset shifts that can improve cancer pain management for our sort of GP vets out there? What could they be doing, or what should they maybe be thinking about earlier to sort of best manage these often older patients, I suppose?
So look, I think for GP vets, I think one big first mindset shift is essentially stop waiting for the pain to become more obvious to treat.
Yeah.
Look, especially with your cancer patients, and that's where a lot of our resources that we have, like especially from like Wasava, become really, really helpful, and they tell us if the disease process is likely to be one that hurts, because we know animals can be extremely stoic and quite robust, especially So like, let's say with bone involvement or oral tumor or invasive tumors or like ones that compress nerves, we basically we should be assuming they're painful, okay, and that pain may be present at the start, even if the pet's not crying, they're not showing dramatic signs. And a lot of our current veterinary pain guidance really supports that a more proactive and preemptive approach rather than a reactive one is so don't wait until they look terrible before we're acting. So that's probably like the first thing that I would say to most GP vets that are managing any sort of painful condition, but particularly in cancer pain. And a second would be to shift away from asking, like, is that painful, yes or no, and instead asking about how the pain is changing that pet's function. So sort of what we just talked about and how it's changing their quality of life. So I'm looking at all those different things that are happening at home. So we're asking about mobility and posture, and we're asking about how the pet is sleeping and if there's reluctance to engage. So a lot of the quality of life sort of questions come in here as well. So not just the physical, but like our emotional well-being and social well-being and how they're engaging with different environments and people. And I usually say like any change from baseline. So is something that we should be a red flag. And that's why like in this case, the history taking and owner observations and videos and things like that are extremely helpful, and why they're really, really important.
Yeah, that's a good one. Yeah.
So the ones that so it's things that we're seeing in the home essentially and over time and the context that matters. So firstly, knowing the condition and I guess where it sits on the pain sort of scale, like how severe it is and what sort of pains it produces. Be like really taking a detailed history and listening to that owner and what their biggest concerns are. Another one would be is that thinking that I get cancer pains or any chronic pains or severe pains, there's a one drug fix. And I think we're pretty good nowadays at our multimodal sort of, our polypharmacy. But doing that from the outset is really important. So we're hitting each section of the pain pathway is really important. So addressing not just inflammation, but maybe a neuropathic component or other like mechanical components. And it might not just be about drugs, but there's also non-drug measures that we can use as well for certain diseases as well. That's extremely important. Okay, so like doing a multimodal approach, not just polypharmacy, but all your adjunct care as well is extremely important.
Yeah, agreed. So it's really a multimodal, individualized approach to whatever is going on for that patient.
100%. And then also like reminding yourself, like a good approach isn't just like it's not just continually adding more and more and more and more analgesia.
Mm-hmm.
That's not helpful for the pet or the owner. But it might be like sometimes it's about like this is where you become involved and like treating the underlying cancer itself is helpful.
Yeah,
and
sure.
It might actually mean like referring earlier, like for oncology. So it might be like referring for radiation, I don't know, bisphosphonates or chemo, surgery, things like that. So like, again, patient I saw this morning, I was like, I can help you, but I think referral is going to be better now at this point because we're so early on.
To best cater for it.
And that's the thing when it comes to hospice and palliative, hospice is part of palliative care. It's about interdisciplinary approach. So it might be leaning on your local specialist, and it might not be referring if the owner can't afford it, but asking their advice, and they're usually more than like they want to help. And then involving your hospice and palliative care vets and involving those allied health, clinicians. So, and not just relying solely on like just your oral medications that you have in your clinic. So, and I guess, like that's sort of like what I would say to them. So like a few different things, but then also it's, is that especially with cancer pain, it's an ongoing conversation. We're not just stopping at one script. It's about rechecking earlier, setting expectations, like you've already said, educating owners again, like we've both said, that's extremely important. So it's more proactive, preemptive is what we want.
I think it's to be flexible in the whole process. You obviously have to deal with the cancer itself, then there might be a treatment component to it potentially, then rethinking it again as we're hopefully gaining control of the cancer, and then we maybe be able to let go of some of those medications. And I think what's very important is it's not all about medications, and there's a whole other world out there. So I often have clients where the dog benefits from physio or acupuncture or whatever it might be. There's a whole other world out there that's not just drugs.
Exactly.
Yeah, totally.
We're really good as vets at getting really we just get into that little corner of just drugs and that's all you can do to help. But there's a big world out there with different things that you can do, and like involving like your rehab specialist sometimes is really helpful. And there's tons of different things, like you said, that we can do to help them. That isn't just
absolutely. Yeah, so I think for me, sort of the key points of this today, Anna, was sort of you really want to listen to what the owners are having to say. What are they describing? If you can, either due to home visits, or I really like the idea of the videos, to sort of take a little look yourself. How does that dog or cat behave in their home environment? Because I agree, in the practice, they're just adrenaline is going through, stress hormones going through. It's all a bit. Yeah.
For me, it's amazing what animals can hide. Like it's just like, and we know certain species are better. And I usually say to most families as well, as like even certain breeds will be better.
Definitely. Understanding Staffy, right? I mean, stoic or terrier.
My example is always like my two dogs. I have a Kelpie and like a miniature pincer. The Kelpie will run on a broken leg because that's what he's designed to do. The Min Pin. Seriously, I was crocheting the other night and he got wool stuck around his leg and he's screaming like he's dying. So like, and again, but that said, remember pain's like that emotion, like for them, it's very, very different, but just remembering that, like different breeds will present differently, different cancers will as well. And the pain will be different, but these animals are just so robust sometimes. And we've designed them to be our best friend. They're listening, and like their job is to be our best friend, and they'll keep working and working and working, and the things they'll do is remarkable.
Absolutely. They're putting on a show for us sometimes.
Honestly, they are. And just like digging deeper into and asking those really specific questions to sort of figure out what's truly going on at home, because usually that stuff is just there bouncing and like wanting to give you love and getting the attention from everyone. So they look great, but they might like look awful at home. And the videos, they're very, very helpful.
Absolutely. And I think the other thing for me that stood out is this really multimodal approach, not just meaning multiple different drugs, but maybe a whole team, there's your GP, there's the owner, there's maybe the oncologist, and then maybe there is a physio person or a holistic vet involved to
or
do it
even
from all angles.
Or like talking to like a local anaesthetist who might have, some other modalities or ways like epidurals and, blocks and things like that, or joint injections. That's I find really helpful as well, especially if the owner wants to approach it like from a gold standard and like do absolutely everything. I think that's extremely helpful, and referring at that point to them before we get those maladaptive pain conditions, I think is extremely helpful. And look, that's in a perfect world. It doesn't always happen, but it's just about knowing that's an option, and then also knowing about those different sorts of pains as well. I think it's important. It's very
important. Definitely. And this has been such an important conversation today. I'm really, really glad that you were able to join on this. I think pain is one of the things owners worry about most when their pets get diagnosed. But I think, as we've discussed today, pain is also something that we can understand and monitor and actually treat effectively when we approach it thoughtfully. So thank you so much for sharing your knowledge today, and the incredible work that you guys do supporting patients and families. I see it every day whenever I send you someone.
So, thank you so much for having me.
No, you're very welcome.
I think is a very, very important topic, and if we can get like even a handful more vets like noticing chronic pain a little bit earlier and asking those questions, or maybe changing their questions that they're asking in their standard appointments, it will make a huge difference. It really will.
Yes. No, I agree. So thank you so much, Anna, for joining this. I will pop it out on Spotify and YouTube for us, for the few followers at the moment. And to everyone listening, thank you for joining us on Couchside Cancer Chats.